Hi, I'm Dr. Valentine, a neonatologist, a registered dietitian, and the chief medical officer at Cape Farms. At Cape Farms, we believe nutrition should work, not just on paper, but in everyday life. That's why our foundational nutrition formulas and shakes are designed to support tolerance, digestion, and whole body health across a broad range of patient needs. Our products are plant-based, certified USDA organic, and thoughtfully made without dairy, soy, gluten, or common allergens. This is science-backed nutrition built for real-life needs. Visit katefarmsmedical.com to explore clinical resources and product information.
Hey everyone, welcome to the Dietitians and Nutrition Support Podcast. Today, I'm super excited to bring to you, I think, a case study in really effective interdisciplinary communication. We have a team of professionals from the OSF Cancer Institute located in Peoria, Illinois. We've got dietitians, a care coordination nurse, a speech language pathologist, and a nurse practitioner who are going to tell us a little bit about how they collaborate and effectively communicate to provide care to their patient population. This podcast was recorded live thanks to a generous sponsorship from Cape Farms. And I'm just so grateful that we had the opportunity to highlight the really fantastic work they're doing here in Illinois. I'll drop their bios in the chat and we'll get started. Thank you so much for listening.
Coming to you from the Dietitians and Nutrition Support Dietetic Practice Group, this is the DNS Member Podcast, where we explore topics relevant to our field. From support line content to nutrition celebrity interviews and everything in between. This podcast is where DNS members can go behind the scenes and explore the driving forces behind cutting-edge nutrition support. I'm your host, Christina Rollins. Let's get started.
It is my pleasure to welcome the OSF team to our podcast. And I would love to start by having each of you share a little bit about what you do and how you intersect with enteral nutrition.
Thank you so much for having us, Christina. We're so excited to be here today. Gina and I are both outpatient clinical oncology dietitians at the OSF Cancer Institute. And we like to say that as oncology dietitians, we really give patients the tools to get through their cancer treatment, make sure they're maintaining their weight and really improving their quality of life. Something that we often talk with them about is throughout their cancer journey, there's so much that is out of their hands and completely out of their control. Their diagnosis, their treatment plan, the side effects, they really have no control over that. But nutrition is the one thing that they can take into their hands and absolutely run with it. So we really work with patients on that, empower them with that. And a lot of what we do is enteral nutrition management. We work pretty closely with our head and neck cancer patient population, and due to the side effects from treatment, the locations of the tumors themselves, a lot of our patients often get feeding tubes. So we help to break down those barriers, we manage the enteral nutrition, and then we help them wean off the feeding tubes at the end. So that's a little bit about what we do, and now I'll pass it on to Nicole. Nicole, you're still muted. There you go.
You all didn't want to just read my lips for the next 5 minutes. Sorry. But my primary role as a speech pathologist on our head and neck cancer team is to make sure that these patients are getting safe oral intake when possible. That may be through doing a clinical swallowing evaluation. I also perform video fluoroscopies, as well as the fiber optic swallowing studies. Based on these assessments, I really determine whether oral safety is intact and we can move forward with an oral diet, or if we need to use non-oral means to support their nutrition. It could also mean that I need to intervene and train compensatory strategies or recommend augmented diets for these patients. I also help manage any toxicities that may be related to voice and swallowing that limit the patient or cause pain. These toxicities like a dry mouth, bad taste, mucositis, any sort of reduced range of motion in the oral cavity, or just, difficulty swallowing, maybe even a lymphedema. They can impact the safe oral intake if it's not managed. So I give the patients education on managing these issues so they can maintain the oral intake as much as possible and as long as they can through their treatment. So I work very closely with our dietetic team, which I find them so valuable. So we collaborate on managing the best nutrition. So patients may be able to swallow adequately, but if they aren't getting enough in, we collaborate to determine what other means necessary to ensure adequate nutrition. So baseline is we want to do all that we can to ensure that their quality of life is as enjoyable, or maximize it as much as we can throughout their treatment and after. So by using this treatment, this collaborative treatment, we can make sure it's beneficial to the patients and not only to them, but for our team. And now I'll pass it on to, let's see who's up next. Jessica.
So I'm Jessica. I'm the otolaryngology head and neck oncology surgery APRN. So I provide comprehensive care for patients undergoing surgical treatments for head and neck cancers. This includes preoperative evaluations, postoperative management, symptom control, patient education, care coordination across the multidisciplinary team. Nutrition's a critical part in our practice because many of the patients, their cancers have to do with the area that they swallow. So it's in their throat and their mouth. So they often experience difficulty swallowing, inadequate oral intake, increased nutritional needs because of their cancer or cancer-related treatments. I work closely with our dietitians, our surgeons, our speech language pathologists, our nursing staffs, our nurse navigators to assess nutritional status and determine need for feeding tube placements, monitoring tolerance of feeding tubes or in feeding in general. But I agree, just to piggyback off of what Nicole had said too. I mean, we want to optimize healing, treatment outcomes, and overall quality of life. And I'll let Catherine take it from here.
Yeah, so I'm the head and neck survivorship nurse navigator. So I work specifically with post-treatment head and neck cancer patients. I focus on helping them manage the long-term and late effects of their cancer treatment and really focus on their recovery and ensuring they can obtain a good quality of life after treatment. Specific to the head and neck population, nutrition and swallowing are so major concerns after treatment. Enteral nutrition is often a part of the conversation and something that a lot of patients deal with long after treatment ends. So I collaborate closely with our dietitians, with our speech language pathologist, Nicole, specifically, and our providers to support any patient who are using feeding tubes, who are trying to transition back to their oral intake, or anyone that's dealing with ongoing nutritional challenges post-treatment. My real goal in this is to help patients feel supported, provide them with resources, and help them regain their function after treatment. We really focus on quality of life and getting patients back up on their feet in the survivorship.
Something that struck me when I first talked with Gina and Gabby, and if you are a follower of the podcast, you probably recognize their names and their voices because they were on our podcast a few months ago to talk about their skills lab. So if you're interested, you can always check that out on our channel too. But something that struck me is just that deep commitment to collaboration. And then as I met the extended team, it was almost like you all were extenders of one another, right? I heard one of the common themes that I heard was, well, if I hear this, then I call Gina, or if I hear that, I refer back to Jessica. So it was like you really had kind of eyes and ears everywhere, even though not everyone was in the room, which I just thought was pretty remarkable. So from your perspective and your vantage point, where does enteral nutrition therapy most often break down in the oncology setting?
That's an excellent question. It can easily break down from the moment it becomes placed. So if there's no plan in place by those who are putting that tube in, no referral, no system set up to make sure that they're getting supplies, education on how to use the tube, access to a dietitian, right, to write orders. Many patients, a lot of dietitians at conferences, note this, it's national. Patients get tubes, and then what? and then you get a call from someone 3 weeks later. Am I supposed to clean this? How do I flush it? And so that is an easy breakdown. And then if the patient goes inpatient and then they're being discharged again, and maybe there was a formula change, or they had it placed inpatient and now we're going outpatient, and maybe the enteral recommendation doesn't fit their home schedule, their home life, right? Our patients have treatment every day, lots of appointments, so we have to make that feasible. So the gaps mainly is when the tube is put in, and then from an inpatient to outpatient standpoint.
So from your perspective, how early should nutrition be integrated into an oncology treatment plan? And then what are you seeing as barriers of why that maybe isn't always happening?
Yeah, I think that absolutely it should be at the time of diagnosis. We know with a cancer diagnosis that oftentimes nutrition is already impacted before we actually have the pathology results that confirm a cancer diagnosis. That can be caused by, cancer can cause appetite loss, weight changes. It can impact our GI tract and the ability to absorb nutrients. And specific to head and neck cancer patients, our swallow function can be impacted by our tumor. So without a doubt, the day of diagnosis, nutrition should be introduced. And then it should be an ongoing conversation at every major touch point with patients throughout their treatment journey and into survivorship. Some of the barriers that we see most often is the referral process, and what provider is going to own that referral, who is going to refer to the dietitian. Is it going to be the medical oncologist, the primary care, the surgeon? And then having the discussion with the patient. Patients are overloaded at the time of diagnosis, and we do so much education, and they're feeling overwhelmed and stressed. And nutrition is one more thing that we need to assess. And it often gets kind of shoved to the wayside. Assessment isn't complete at the time of diagnosis. So making sure that nutrition assessment is done thoroughly upfront is so important. And then patients also experience a lot of appointment fatigue at the time of diagnosis, because we are loading them up with appointments with different providers and testing and all this stuff that they have to go do. And they're just like, oh, a dietitian appointment? Like, I don't want that. That's one more thing on my plate that I don't find that I need right now. So really the education of why it's important straight out of the gate is really, really key.
Mm-hmm. And I think with our collaborative model that we use, we overlap quite a bit on educating the patient on these issues. So we have a wonderful pre-treatment clinic that we can all chat with the patients in. And I think we all hit on the importance of nutrition at that time. And to piggyback again on what Catherine said, the patients are exhausted at that point, and we really need to prioritize what appointments are absolutely necessary and which ones, can take a back burner. And a lot of times, unfortunately, doing pre-treatment assessments, they don't want to drive all the way into the hospital for, a swallowing study when they know they're swallowing okay, or they feel like they're swallowing okay. So a lot of this is, treat as we go. And communication, I feel like, can be a barrier for getting the nutrition status as stabilized as we can beforehand, because of patients don't come to see necessarily our level of providership. They'll see the physicians, get the game plan to treat their cancer. They want to live, so they want to get those treatments completed rather than the, managing toxicities, making sure their nutrition's okay, making sure that they know how to treat their symptoms when they develop over the course of their treatment. So it is an ongoing discussion that we have, and we are all lucky enough to have our team. So when one person gets word of something, I get messages from the dietitians a lot. I get messages from Catherine. Jessica may have seen them in the clinic about issues that are going on with the swallow that I just am not aware of, because I'm not able to get the patients in as frequently as I would like, because of that fatigue. So we're in a really nice situation at our clinic, but I think making sure anybody who is not as lucky as we are to have a team like this, making sure you communicate or finding somebody who can check in with the patients throughout their course of treatment as much as possible to make sure none of these difficulties develop before the problems get too bad to be treated, or you have to treat them a lot more aggressively.
I think you guys paint a really nice picture of clear communication to the patient and really sharing why are these things so important during your cancer care journey. When we think about communicating with other disciplines or other healthcare providers, communication sounds easy, sounds like kind of a no-brainer, but we know in practice it doesn't always happen that way. So from your seat, where are you seeing some communication gaps between disciplines? And then how does that kind of impact or connect back to feeding tube management?
Yeah, I think with enteral nutrition, this is a national issue where there can be a lot of gaps in feeding tube care. You can have so many hands in the pot, but no one wants to necessarily own something. And so there can be just big gaps in communication and gaps in care there. Everybody's so focused on helping the patient, but there might be things that just fall through the cracks. So I would say with that, the biggest breakdown that we often see is like patients can get feeding tubes placed in the outpatient setting. And then there's either no referral to a dietitian, something happens with the referral, and patients can go months having a tube, having no idea how to use it. Another big thing is who's going to teach the patient how to use the feeding tube. If a feeding tube is placed in the outpatient setting and there's no referral to a dietitian who can teach them how to feed, how to do site care, or no referral to home health, a lot of patients are left there without any tools. So we've been able to really streamline a process there where we have open communication with not only us here at the Cancer Institute, but our fellow mission partners. And so the biggest thing I would say there is if you see a gap in care there is reaching out to the teams that are placing the tubes, reach out to GI, reach out to IR, see if they have a syringe there to give your patients after they get that tube placed, if there's going to be a gap where the home infusion pharmacy can't get formula to them for 5 to 7 days. And see if you can discuss with those outpatient facilities about automatically placing a referral to the dietitian. We've been able to really close that gap there, and our patient outcomes have been so much better because we're able to intervene so much sooner.
Thank you for sharing that, Gabby. That was really good. I know that sometimes making those phone calls can be challenging if you're not connected. Now, you mentioned mission partners, so other organizations or other locations within your organization. But how do you approach somebody who's maybe outside of your health system, maybe someone you've not talked to before? How do you build that trust so you can have that collaborative partnership?
Gina, I would definitely say you could talk on this one. You've taught me so much in this aspect, so take it away.
Yeah, so we see a lot of patients in rural, smaller hospitals getting tubes put in other areas. So I work a lot and I make a lot of phone calls, is this so-and-so's doctor's office? I'm calling on a mutual patient, right? And explaining your role and just building that rapport right off the bat and making the effort. It's an extra phone call. It's not easy because they're not in my EMR system to communicate. I'm on hold a lot sometimes. I'm playing phone tag with nursing staff, but building that communication. And then I always like to ask, hey, now that we've connected, what is the best way for me to communicate with you moving forward? Do you have an email? Some providers give me emails, much easier. Certain extensions, some direct cell phone numbers, right? And so once you make that connection, ask how they prefer their communication method so you can reach them at a faster pace.
Your team, how have you all defined role clarity? So like who's doing what, who's making the phone call, who's taking point on different things? Like how do you all manage that and any potential overlap that could occur?
Yeah, so typically what we do there is if we assess the patient in office and we really feel like a feeding tube is necessary, whether they're malnourished, having difficulty swallowing, let's say they have a head and neck cancer where the location of their tumor, they're getting radiated, we're expecting them to have a lot of toxicities. we'll chat with the team right off the bat. And I think something that we do really well is asking questions and seeing if everybody's on board with it. Because we might think this tube placement is absolutely necessary, but a provider might say, hey, due to the location of their tumor, a G tube isn't appropriate. I don't think they're going to have X, Y, and Z toxicities. They're a difficult intubation. We don't want to put the patient under sedation again. So having that open conversation is super important, and just saying, like, here's what I'm seeing from my point of view. Here's why I'm recommending this. What do you think there? So often we'll have that conversation with Jess, or she'll even catch it before we do. She's so good about initiating enteral nutrition early because we know it improves patient outcomes. So she'll refer to us right off the bat for a nutrition eval. And then we'll say, yep, we're on board with placement. And then we'll automatically refer out to our GI clinic where they'll get the patient scheduled for the feeding tube placement. The nice thing about the GI clinic here is they have auto referrals to dietitians. So we often get double referred, which we say is great. We'd rather have multiple referrals and then none at all. Our GI clinic provides our patients with a syringe. That way they can flush their tube. And then next day, we typically bring them in office. If they're a patient that's close to our location, teach them how to feed, teach them how to flush. Our dietitians here place the referral to the home infusion pharmacy and get the provider to sign off on the order. And then we kind of manage from there on out and just keep the providers updated along the way.
I feel like
that comes. Oh, sorry.
Sorry. I was going to say, I just feel like the surgeons are very receptive to your guys' feedback. And say we're doing a big head and neck surgery for a large cancer, a lot of times they'll just go ahead and place the peg themselves too, knowing that what's to come and what's kind of to be expected, and after discussion with the whole team. So it's really great. They're so receptive to it.
Yeah, I agree. And I think too, one thing is like when you're stepping into a role as a dietitian in a clinic with other providers, letting them know, hey, I can do X, Y, and Z, right? So one thing with Jess and I that has worked out is I can put in a referral for the enteral nutrition prescription, and it's an easy click for her. So it's owning the space you need to own and letting the team know the steps involved. So again, is that communication? And then some of it will absolutely overlap, such as if I'm over here trying to titrate up an enteral rate, but they're in clinic and speech is now saying, great, you can eat safely. Let's work on improving your hunger fullness cue. So we may taper off that tube a little bit. And so she'll let me know so I can now provide an intervention for that. So there's definitely that overlap. But again, it always is going to come back to communication and sending updates in your team.
So what happens if somebody disagrees? You've made a recommendation, you're like, this is solid, this is exactly what they need, and somebody else maybe isn't on board. How do you handle that?
Yeah, I mean, I think,
Yeah.
Oh, sorry, I was going to say, constructive, healthy disagreement is kind of a sign of a strong interdisciplinary team. It just means everyone's advocating from their own expertise in their area. When nutrition recommends early tube placement and, say the oncology, the surgery team's hesitant, we just try to focus our conversation on the patient's current status and where we're anticipating the patient to be in the next coming weeks. Are they already losing weight? Is their swallow functioning declining already? What treatment are they receiving? And what are the side effects that we're expecting? So we really look as an individualized multidisciplinary approach to these patients.
And they probably get the most pushback, or I don't push back so much, but hopeful that they don't put a tube in some of these patients. As we all know, everybody's got different personalities. The patients do, different home life. Some people are forward, we're going to tackle this cancer. And other people are like, just take care of me. So they'll start to rely on that tube to, support their nutrition and stop eating because, you don't eat and you don't swallow, then you kind of lose the function. But again, our team, we want to do what's best for the patient. So a lot of times I have to recheck myself and say, you know what, if they're not strong enough and they need that extra nutrition and, hydration and all the good stuff that comes along with the enteral nutrition, I can still really promote the oral intake. And that's where Gina said, where we overlap a bit, making sure that they have enough intake to support themselves, but I need, a little space in there so I can keep them motivated to keep eating and maintain that swallowing function. So again, it's just really communication, making sure we all know, what the goals are for the patient.
Well, I think that's the benefit of having a multidisciplinary team is, Nicole, you're going to hear things in your treatment that Gina or Gabby may not hear in a nutrition intervention or vice versa, right? So if you can share that information and bring those perspectives together, then the patient's plan of care is going to be that much stronger.
Set up that way, right? If you're kind of siloed in different locations, you can still find a way to communicate and keep them updated. I worked at a facility where not all my providers were in the same building. And so it just was a little extra legwork on my end, but you can still strive for that as the goal.
And I agree with you on that. A lot of times in other locations that I've worked, nobody wants to really explain their expertise or let everybody know what they know. And it's so important that you do start communicating, because once the providers know what, help you can offer them to manage these patients, they'll start reaching out more and your bond will get stronger and communication will get better. If you stay quiet and just let them kind of muddle through them managing it, you think they know more about your specialty, but they probably don't. So as a dietitian, tell them what you know, tell them what you can offer, tell them how they can better their treatment for the patient. And I know they'll appreciate it. So don't feel intimidated, like, I'll just let them make the decisions. Help them make those decisions and share with them, what you know and what you can offer to make this patient's journey a little better.
So have you all found any specific tools or structures like rounding or, tweaks in the medical record or protocols that have improved your communication structure?
Yeah, for the outpatient setting, I think that one of the best things that we have ever done to improve communication is multidisciplinary clinics. So us seeing the patient as a team in one appointment all together. So the dietitian is present, the provider, Jessica, is present, Nicole is present, and we all interact with the patient in one setting at one time. And the best thing about that is you get real-time communication. And then as a team, you can plan interventions. So that makes a huge difference in communication. And I know that isn't always a possibility for all settings and every team out there, but it is really beneficial to the patient, and it also creates better outcomes, and it creates a lot of patient satisfaction as well. I think also having a really good referral protocol in place is important. We in the past have used the MST screening tool. And the navigator at the time of diagnosis would use the MST screening tool to determine what nutrition risks the patient is at and what their current nutrition status is. And then that would dictate if it required a referral to the dietitian. And it really helps to keep the patient from falling through the cracks. I think also you really have to use Epic Chat if you're on Epic or whatever your EMR way of communicating, in basket messages or like Teams messages or anything like that. Constant real-time communication is so important. So that back and forth communication. I think the other thing that I would highly recommend to improve communication is being visible to your team. So not hiding in your office and staying siloed, but if you can be present and not just be the other end of a referral, if you can get out into the clinics and see patients at the same time as the physician, or even doing like lunch and learns and educating the team about dietetics and about tube feeds and everything. And once the doctors and once the team get to know you as a person, communication just automatically flows much easier.
Our listeners, because you guys were not on the pre-call when we all got together, they were all together in the same room, and I had to ask them to separate just for the purpose of audio visual control. But it's very evident that you all are a very close-knit in-person team. And I think that's just phenomenal. So kudos to you all for structuring your day that way.
And you know, Christina,
yeah.
Oh, sorry. I was just going to say that kind of flows into one of the questions I wanted to address is, you know, they mentioned so many skills as a dietitian to have, right? Be visible, be present, communicate. And I really thought a lot about the question of, you know, like what strategies that we have done that have been beneficial to build trust between providers and discussing a two placement. And that was my favorite question. So I kind of wanted to make sure we get there. And I actually was on the phone last night with a couple of the doctors and providers, and they gave me some excellent viewpoints because as a dietitian, I can teach other dietitians what I do, but I wanted to know as a provider, what worked, right? Like what stands out to you? And it just blew my mind, the insight they gave me. And so for some of them, it was all of them being present, show face. I don't, you know, they have so many things they're thinking of. Oh, that's a dietitian. Oh, that's a dietitian, right? Be present and be available. They really like that they could get a hold of me very easily if they had a question or wanted to update me. Their time is precious. Our time is precious. So instant communication, educating them. So the lunch and learns, things like that, that felt very inspired for a lot of them. Feedback too. So letting them know, hey doc, thanks for suggesting X, Y, and Z. It really helped the patient. It's giving them positive affirmation, which is improving their then future skill set of intervening. But one thing that I know we all work with is tough personalities. And maybe that's more cliche known in the inpatient realm. And how do you get along or break that ice with a tough personality or a provider that maybe does not think a dietitian could be beneficial or utilize that service, right? And so I know I like to walk in with humility, but also one doctor told me his co-residents really respected when the dietitian tried to be the friend and not the foe and bring up ideas in an open-ended way, not necessarily this is what we should be doing, but an open dialogue, showing a united front in front of the patient, and then outside of that room, bringing up a suggestion or care. And so, you know, bending yourself a little bit in the short term can make for a long-term success.
We have a question from one of our listeners, and I think this is a really good point to ask it. So I'm going to jump ahead from our Q&A. So Catherine mentioned how important it is to be visible with your team. So how can this be applied to individuals in a remote work setting? You know, we know that there's hospitals with staffing issues, and they may be using remote dietitians to help, which is awesome, but then it breaks down that in person. So how can these thoughts or concepts be applied to individuals in that type of situation?
Yeah, that's where I think things like lunch and learns come in really handy if you're within a reasonable distance or can do like Zoom meetings or something. Offering, you know, a time where you can say, hey, I want to present some education to you from a dietitian's standpoint on enteral feeding, or, you know, what the dietitian's role is in oncology care or something like that. And then offering, you know, anything where you can get your face there and do education. And I think that's a great way to do it. The other thing is picking up the phone. A lot of people are afraid to call doctors or call providers, and don't be fearful. Like, yes, there can be difficult personalities out there, but it makes a huge difference in building respect if you actually talk and not just, you know, shoot a in-basket message to them, but actually have that real-time in the moment communication. Gina or Gabby, do you have any other suggestions, or Jess?
Yeah, I would say too, I used to work at a hospital where I worked with a lot of providers that worked at multiple campuses. So I would have to do the same thing you recommended, like pick up the phone and call them. But I would even provide like little updates like, hey doc, I'm seeing this patient today. Like, here's what I saw. Here's my plan of care. Let me know if you have any disagreements or want me to do anything else. And I think even just doing little things like that, you're not necessarily going to be a burden to the provider. I think that you're going to see that you really are part of the care team and that they can rely on you. So I would definitely say communicate as much as you can there. That way they see your name popping up and then they'll kind of remember, oh, she messaged me on this patient yesterday. This is good.
And having them, I email a lot of our remote clinics handouts that I want the patient to have for the next day, right? So giving them resources and building that communication. And then they'll be like, oh, hey, do you have any more handouts for X, Y, and Z? This patient's having difficulty.
Yeah. And I think for specialty work, I'll often get referrals on patients that I may not be able to help significantly, or the doctor has used a unique diagnosis or something that doesn't really hit directly with speech pathology. But when I respond to them to let them know that, I offer my skill set, like, this is what I do, this is what I can help you with, and just put it in a quick chat or an in basket, something like that, so they understand what I do, what I can offer. And that would definitely pertain to, any of our specialties. Like, this is what I'm looking for. I think I got a message from an allergist who had given me a strange referral, but then I went into detail about some of the diagnoses and treatments that I can help her with on specific diagnoses that allergists see. So she was very receptive and said, thank you. I didn't know where to refer these to, but now I have a better understanding of it. So I think sometimes they just have so much to deal with and so much to know, they can't know everything. So if you can let them know what you're able to provide, that's helpful too.
I think that's a great point, and really goes along with what Gina said about the friend, not the foe kind of experience. Like, even if they do kind of like you said, Nicole, the referral wasn't necessarily appropriate for what you do, but you presented it in a friendly, like, we're still on the same team kind of way. Like, this is what I can give you. Like, that's going to stick with, I mean, that would definitely stick with me. And I know it'd stick with any provider where, this is somebody that I can confidently go to and continue to utilize.
Yeah.
Jump into a couple of technical questions, and we do have another question in the chat, so we'll get to that here in just a minute. But what clinical triggers or red flags do you see in your patient population that would prompt earlier or a more concerted nutrition intervention?
Yeah. As dietitians, I feel like we are constantly looking for signs that a patient is starting to trend in the wrong direction. And so I really think that we need to focus on that, but rather than waiting for a nutrition crisis to happen. Weight loss is obviously, a red flag that a lot of us see, but reframing the mindset to not just looking at that, but looking at other things. At certain meals, are they saying that they're eating a little bit less? Have they started to eat? They used to eat 3 meals a day. Now they only eat 2. Are they starting to rely more on liquids to maintain their weight than their solids? Are they taking, 2 hours to finish a meal, avoiding textures? Are they struggling to swallow? Those are all really huge signs that we need to intervene. And sometimes you might see, oh yeah, a patient is maintaining their weight, but when you ask them more prompting questions, they're trying so hard to do that. In the head and neck cancer population, obviously, we're really focused on pain with swallowing, pain with eating. Dehydration is a huge thing that we deal with a lot. We just want to make sure that we're not waiting until the patient gets to the point where they literally can't eat. They're so dehydrated that we put a tube in and now they're at a refeeding risk and they have to be hospitalized for it. So staying ahead of the curve with this and really predicting these challenges right when you see the patient is so important. And early intervention is always easier to manage and triage than waiting till really bad severe malnutrition at the end.
Head and neck or GI cancers, how are you coordinating timing between surgery, radiation, chemotherapy, and of course a feeding tube insertion if needed?
Yeah, I can field that one. So typically with the feeding tube timings coordinated through a multidisciplinary approach, sometimes we have head and neck tumor board every Friday where it's the surgeons and the radiation oncologists, medical oncologists. We'll talk about plan of care moving forward and what we're kind of anticipating, and discussion can be at that time. It can be at the very first visit where we, talk to them and have a kind of an idea of what's going on. We all assess each patient's nutritional status, swallowing function, disease burden. and treatment plan to determine whether prophylactic or reactive tube placement is most appropriate. For patients anticipating or that are anticipated to have significant dysphagia, prolonged postoperative recovery, or concurrent chemoradiation, feeding tubes are often placed before treatment to avoid interruptions with the therapy. So for others, close monitoring and allows us for quicker reactive placement of the tubes. Oh, I think you're muted, Christina.
Gosh, sorry, I did it too. So want to hit one of the questions in the chat. So once we have a patient with a feeding tube, what type of formulas are you using? And this person says they work in home care, and one of the hospitals they work with only uses elemental feeding formulas with their head and neck population, and they're just curious about the reason why.
Yeah, so we use a lot of elemental or semi-elemental peptide formulas. We've seen a lot with the head and neck population. They can become very malnourished very quickly. A lot of them are getting, concurrent chemotherapy and radiation at the same time. And so their mucosal lining in their GI tract is very inflamed from the combination of the two of those things at a time. So, we've tried in the past starting them off on a standard formula. Historically, they don't do great on a standard formula. The chemotherapy is wrecking their GI tract, so they can have awful, diarrhea, nausea. And so then partway through, you're having to stop, give them a new formula to try, pause orders at the home infusion pharmacy, and then by the time you get their enteral nutrition prescription changed, they're already done with the treatment and have lost a lot of weight. So we like to be reactive in that scenario where we're just starting them off on a peptide or an elemental formula because we don't want to have problems partway through and compromise the patient's nutrition status. Unfortunately, with the chemotherapy itself, it can cause significant malabsorption. So that right off the bat gives you an indication to use a peptide formula starting off.
And I would say too, in the home setting, we also do a lot of combo of a elemental, semi-elemental with a blend as well, or a blended, peptide. And so that with a lot of the reflux and things, people want, they have more satiation with that. So we combo it. So don't be afraid to explore unique variations. So we often definitely always do peptide. We like to do in blends if they're not ready for blends in treatment. Try it again later on down the road. It helps wean them and give them more nutrition.
Thank you for that. And we have another question from a listener. I work in a hospital setting where dietitians historically have had very little direct interaction with physicians and NPs. What advice would you give for starting to build those relationships and becoming more of an integrated member of the team? Or did you all have a specific turning point or a strategy that helped shift that provider perspective from dietitians being a resource rather than an afterthought?
Yeah, I love that question. I would say ask to join rounds, right? Start there, get to know who's who, and start to have input with them, conversate with them, start in a friendly manner and to build up so they see you and building that trust. Just like any relationship in our lives, personality wise, a surgeon I worked with who at first we did not communicate or collaborate, and now we're like best friends. But he told me it takes time, and just like any relationship, it's building that trust and that camaraderie together. So show up at rounds. Work with the nursing staff, find nurses that you can reach out to if you feel intimidated to go to the doctor or feel like the doctor may turn down your idea, and use their APPs as well.
I'll second that. Utilize your nurses. Honestly, the nurses interact with the doctors a lot. I think more than the inpatient dietitians. When I was an inpatient nurse, I feel like we were almost an intermediary, and I think the nurse is a great gateway to getting to know your physicians, and they're also part of the interdisciplinary team, and so having a relationship with them will really benefit you in the long run.
I have had many times where I have grabbed a nurse here and said, "Hey, I'm scared to go chat with this doctor. Will you introduce me or invite me in on clinic?" And that's where like our bonding began. So the nurses, they can mama bear the doctors really well. And so I like to fly under their wing a lot with things. And I'm not, too scared to say that.
Yeah, I think one of the best pieces of advice I got from a CMO like a long time ago was he just said, just show up. He said, if you just consistently show up, eventually people start wondering like, where is Christina when she's not there? Like you become part of the team just by interjecting yourself into that environment. So we have another question. In your opinion, why do you think interdisciplinary education doesn't always work in practice as nicely as it's presented in theory? So for example, sometimes as dietitians, we might not feel our work is being valued and respected as members of the interdisciplinary team. But in education, we hear that it's always valued, it's always recognized. So why do you think there's a disconnect there?
Well, maybe they, the doctors or providers or team never worked with a dietitian before. So they kind of are keeping it at bay. Maybe you have someone that truly thinks they know what all nutrition is, right? There's people out there that think that and want to just have that control. So, breaking down that barrier, chip it away piece at piece, pick one thing where you can kind of show, hey, look, bending a little, for yourself will make a long-term impact. And I've had to do that with many providers and that they felt, I know all things nutrition. That's not a real study, and proving to them little by little. It's exhausting. Don't let it defeat you because in the long run, it'll make your life so much more enjoyable at work.
And a lot of the physicians are research-based. So if you show up armed with your research, armed with your statistics, pertinent to whatever patient they're talking about, they're going to listen. Because we had an issue in the hospital about waiting to do a swallow evaluation on patients that have been extubated. The physicians wanted it done immediately. And we said, there's laryngeal edema immediately post extubation. We don't need to do this. And the physician looked at me and he's like, then show me the research that says that. So that's what they want to hear. So if you're loaded and they know that you know what's going on, that you read, that you know what you're talking about, I think that will hit them a little harder than, just saying, oh, he needs a feeding tube. Give him your stats, tell him why. And that's what they start to notice and listen. They know that you know what you're talking about. So unfortunately, we have to prove it sometimes, but use a little research and data and they tend to listen a little more.
And then your schedule too, Christina, I think is a big thing that ideally we'd love to have everyone at a multidisciplinary clinic, but not all schedules or staffing can allow for that. So you may just have to, figure that out. And that's a tough one. That's a tough one to overcome, getting another dietitian on board or making it work. So in theory, I'd love to have MDC with all the types of cancers here, but we don't because of staffing and schedules.
We just have a few minutes left in our live podcast. So I would encourage any of our listeners, if you've got a question, please drop it into the chat. I did want to touch on, because I think we've talked a lot about strategy, like strategies for team building and communication and all those great things. But there's also that old saying that culture eats strategy for breakfast. So in your experience, what leadership behaviors have helped you foster that culture of interdisciplinary respect around nutrition care?
Yeah. Leaders that welcome the dietitians into the clinic that needs to be a commonplace thing. We need to have an open door. From a leadership standpoint, they need to create a culture of an open door to the dietitians. I think promoting a team approach to patient care. And then something that's huge and I think often is underrated is managing up your team members. So you need to constantly be to the patient, to other providers, telling them, oh, the dietitian is wonderful and she can do this for our patient and she can come in and educate and help troubleshoot this peg tube, and, like really promoting each other to, and leadership promoting to the team, the dietitian, the different team members, and providing that very positive environment is huge, and leadership really needs to be involved in that.
Mm-hmm. And I also think, if we can get leadership to be flexible about their thinking, not only, trying to be productive in their billing or whatnot, but allowing employees to be flexible, because I can't tell you how many times we'll have a patient in the clinic and we're like, somebody email the dietitians right now. And they can usually get up to our clinic and help us within 5 minutes. And it's amazing. The patients are impressed. Like, the entire team has given their 2 cents in each of their specialty areas. And the dietitians are right there. They'll bring samples up. They'll help the patients troubleshoot. They'll educate us on what, we need to do. And we always hang around and listen because we all learn from them. So, by allowing people to jump in and jump out and not relying on a, strained schedule, or everybody, you see him at 10, you see him at 11, allowing people to pop in and out in a clinic format is really, really, really helpful to everybody.
Well, my last question before we wrap up, if you all could implement just one system level change tomorrow to improve enteral nutrition collaboration in the oncology space, what would it be?
100% it would be the smooth flow of inpatient care to outpatient care. There are so many barriers related to that, and we have got to get great processes in place so that the patient is really well cared for in that transition.
I think something that could definitely help too is, like, when I used to work in an inpatient setting, if I saw a patient that I was like, I really think this patient needs an outpatient dietitian, or saw that they were following with an outpatient dietitian in the past, I would reach out directly to that dietitian and say, hey, I saw that you saw this patient a month ago. I saw them in the hospital today. Here's what I did. I told them to call you when they get home, but if they don't, if you could check up on them, that would be great. There can often be like a big gap in care there. So if you're just really being intentional about communicating inpatient to outpatient, it's going to improve patient outcomes so much. If you're an inpatient dietitian and you see that a patient had a feeding tube placed, it's a brand new tube. Let's say you trialed them on a formula for 1 to 2 days. A lot can happen after they go home. They might tolerate that formula for 2 days, but then when they go home, they might fall apart. So making sure that there is an outpatient dietitian there to manage them is crucial. Like, don't just document in your note, recommend referral to outpatient dietitian, because most likely nobody's going to see that. I've been guilty of doing that in the past, and I realized, oh, hey, I actually have to reach out to the doctor and say, hey, this patient's going to need an outpatient dietitian to manage their enteral nutrition from here on out. And so helping fill that gap in care is really going to improve patient outcomes.
Mm-hmm. And just to add on that, I always appreciate when you reach out and I'm like, just tell me what to do so I can help you with the patient and facilitate. So yeah, it really helps to just have that communication and that visibility.
Mm-hmm. And our dietitians, from a speech standpoint, they catch a lot of people that are relying only on the enteral nutrition, and they just sit, if they've had some dysphagia or been placed NPO, or they've had toxicities that they aren't able to eat. The dietitians a lot of time catch that they haven't been seen by a speech pathologist in months. So these patients are just sitting there wondering what's going on. So if you do have patients that you're managing from a dietary standpoint and they're not eating and you're not sure why they're not eating, reach out to speech or get a consultation so we can get them back to their oral intake when possible.
Well, thank you all so much for sharing your expertise and for giving us all just a glimpse into your amazing team. I mean, I think what you guys are doing is really a gold standard. You guys are doing such great care for your patient population. So thank you for sharing that with us. I think this conversation really highlights that optimizing nutrition care isn't just about formula. It's not about calories. It's not about types of feeding tubes. It's about building relationships, effectively communicating, and having that shared sense of accountability. So thank you for everything you're doing for your patients and for sharing it with us today. And to our listeners, thank you all so much for joining us live. Be sure that you visit our website at dnsdpg.org. And if you're new to the DNS podcast, we invite you to subscribe on Spotify, Apple Podcasts, or wherever you access your favorite content. Until next time, I'm Christina Rollins. Thanks for listening.